First of all, you have to learn the trade before learning the tricks of the trade. This is what I tell my students.
Just 24 hours a day. You are doing surgeries, you are having travel plans, you are giving international presentations. How do you manage time?
Time management is everything in life.
Like, it's not about the time, and it's also about the mind management. Like, when you are doing the surgery, you are fully into it. When you are with family, you are fully with the family.
It is about compartmentalization. So you need to then you enjoy what you're doing, and then success automatically comes in. Money is secondary. So my advice to the younger generation is, don't think about money, don't go after money.
How LASIK works in the treatment of myopia?
See, LASIK basically is laser in situ keratomelusis. Most of these patients are also in the rural areas, and they don't know that a surgery can cure them. So there's illiteracy, lack of knowledge. Also, there is difficult to access eye care.
Myopia and cataracts are major eye concerns in India right now. The way Virat Kohli is referred in cricket, a legend, same way Dr. Shri Ganesh is in ophthalmic field. He is one of the fastest surgeon in the world, and he has been nicknamed as Feko Maverick. He is the founder of Netradhama Super Speciality Eye Hospitals, which are located in Karnataka. Has done 130,000 cataract surgeries and more than 80,000 refractive surgeries. He has more than 120 research publications. He is on the advisory board of major manufacturers, and he is guiding them to take on better path and making that innovation accessible to every patient. So let's welcome him. First of all, sir, thank you so much for accepting my invitation and making time for this podcast from your busy schedule. It's been an honor for me that you are sitting in front of me, and I think like this podcast will be going to be a very, very insightful talk with you. We will get to know about your personal stories, your experiences, your success stories, your challenges you faced, and a bit technical information for the patients regarding cataracts and myopia. Thank you so much, sir, for accepting my invitation.
Thank you. It's my pleasure.
Thank you, sir. So, sir, as I was reading about you, you have started your clinic in 1994, and then you came to 8 hospital chains in Karnataka in 2024. So, sir, this must be an amazing journey. So, please tell me something about this journey. Like, how was it?
Well, there's always an interesting story. And I was actually a very good student, both in MBBS and MS. I got the gold medal in second year MBBS and final year MBBS, and also in MS for the university. But then during our times in the 90s, doctors were not paid very well. And I could not land a decent job. I mean, we were getting salaries of 3,000 rupees or 3,500, which was something that a plumber or a mason would get. So it was not really kind of worth taking up those jobs. So I decided I will start off on my own. So in 94, I started in a small clinic. It's a one-room clinic. And even to get equipment was difficult because I had to kind of beg or borrow because I didn't have a balance sheet. And the bank does not give you a loan if you don't have steady income and a balance sheet. So I had to borrow from parents, relatives. And there was a small house. It was a residential house, which my father had given on rent, and the tenant left. And so I asked him, if you can give me the house rent-free for 6 months, then I can set up my clinic there. And of course, my parents supported me. And I started my clinic. I was very confident because I knew my subject. Of course, I started among very big players, big hospitals in and around me. But then I was quite confident that I would make it. And I remember during the inauguration of my clinic also, I had to hear a lot of comments in the sense that, oh, don't worry, you'll always get those patients who keep going around to all clinics because, they have conditions like optic atrophy or retinitis pigmentosa and all that. But then, yes, I kind of put in all the hard work. And initially when I started, I didn't have any assistants. So I used to clean the OT myself. I used to clean my instruments, sterilize them myself. Of course, my wife helped. And we both used to sit and scrub the OT in the evenings. And so it was a small beginning that I started, very humble beginnings. But then, my dedication to this profession and to my patients helped. And over a period of years, the practice grew. I was always techno savvy and I embraced all the new technologies. In fact, when I couldn't afford it also, I was one of the first to start phacoemulsification. Phacoemulsification for cataract. So I started that in 95, just 1 year after I had started my practice. And then I was getting like 4 or 5 patients to operate in a month. But I took the risk, invested in a machine, got the machine, and then started off. And that was a turning point in my career. And I was very good with doing cataract surgery with phacoemulsification. There were very few surgeons who were offering it routinely. And then I started topical anesthesia. In fact, I was one of the first or the first to start topical anesthesia, that is without injection, stitches or bandage in Karnataka. And then patients, by word of mouth and the results, they started coming in and the practice started growing. And then I also invested in a LASIK machine where even the big practices had not invested.
So you borrowed that money to introduce that LASIK machine?
I borrowed money from a cooperative bank paying very high interest. And it was around $400,000 US at that time. And mine was a small practice. So the distributor for this machine, it was called the Chiron, or then Bosch & Lomb took over this company. And when I sent an email to them asking them to send a quotation for the machine, I didn't get any reply. Again, for repeat emails, there was no reply. So I had to call them up and ask them, are you in the business of selling lasers? Because if you're in the business of selling, I'm interested in buying one. And then immediately they came down. And I remember we sat in Holiday Inn, now it's Lee Meridian, and up till 2 a.m. in the morning and finalized the deal. And they say that was the fastest deal that they have done. So I took a lot of risks also. But then I was trained in LASIK in the US under Dr. John Shepard. He was one of the pioneers in cataract and LASIK. And they were doing the FDA studies when I was there doing a observer fellowship with him. And I knew my stuff and my art and craft.
And so you was also doing ghost surgeries for your professors. I heard that.
Yes, when I was a student, I was quite skilled and talented. So many of my professors used to get even their private patients operated by me. And in fact, as a student, I have done all varieties of surgeries. I had done cataracts, retinal detachment, squint, over 150 intraocular lenses. Then as a student in those times where only, the 3 or 4 of them were implanting lenses. In the early 90s. And so I actually enjoyed my post-graduation. And I was actually a complete surgeon by the time I finished. So I was very confident of starting practice, and because I couldn't actually land a decent job, now I'm thankful that I didn't get a good
You didn't get a decent job.
And I started my practice, and then it has grown. Now we just opened our 9th hospital in Whitefield.
And so that's very beautiful.
There are a lot of initiatives. I mean, it's not only the looking after patients. Of course, the patient is the core of our practice. So everything revolves around the patient satisfaction, results. But we are also into education and educative initiatives. We have residency in ophthalmology, the DNB, which is a 3-year course after MBBS by the National Board. And then we have postdoctoral fellowships in different specialties like phaco, refractive surgery, glaucoma, retina.
Mhm.
So people come from all over the country and even abroad to train now.
Okay.
So at any time, we have about 30 fellows with us who are training
Who are training per year?
in different specialties.
Okay.
So every year, about 8 to 10 fellows
Okay.
pass out.
Pass out.
It's like a 2-year course,
Okay.
postdoc fellowships. And this is affiliated to the Rajiv Gandhi Health Sciences University. So
Okay.
this is something that we are doing. We also have a BSc in optometry and
Okay.
an MOPT,
Okay.
which we have the Netradama School of Optometry. So this
sir,
is for paramedical training, like optometrists, the primary care people in eye care. So they actually do the refraction and vision testing and all those tests before the doctor sees.
Sir, I can say that it's not just the hospital, it's a full institution which
Yes,
is also giving education to the doctors also. It's giving like courses in optometry also.
Yes. So, and we also have short-term training programs.
Okay.
And observership. So we have people from all over the world coming in because we have some of the cutting-edge technologies, first time in the world, first time in India kind of technology. So they come and observe and learn. So it is actually very fulfilling. I mean, to even teach. So because I am very interested in teaching and training. Because if you alone are actually good and operating on patients, then there's only a particular number of patients that you can treat. But if you're teaching somebody, then it spreads.
Yes.
So now I have over 200 fellows whom I have trained, and they are all doing good work. So it is, it keeps multiplying. And
so you are the perfect example of just follow your passion. Like the path will lead to somewhere.
Yes, if you love what you do, then there's a saying that you don't have to work a single day in your life. So if you love what you do, then you enjoy what you're doing, and then success automatically comes in. You know, money is secondary. So my advice to the younger generation is don't think about money, don't go after money. Think about how you can be good at what you're doing and give your best. The money is secondary, it will automatically come in. You don't have to bother about it.
Exactly, sir. So like with experience of like more than 1,40,000 cataract surgeries, 80,000 LASIK surgeries, refractive surgeries you have done. So sir, there must be a lot of challenges you have faced during this span of like experience. So sir, what are the major challenges a doctor faces?
There are a lot of challenges, especially when you embrace new technology. One is the cost of the technology. And then you have to know how to use the technology optimally. And if something goes wrong, you should be able to handle it. Something goes wrong with the machine or during the procedure, you should know how to handle it. So these are all challenges which are there. Even purchasing the equipment again, because doctors are not very good businessmen. We are never taught about business or business skills during our course. We just taught about how to treat patients.
Treat patients.
And so our focus is basically on the patient. So this is again a challenge because these equipment, they're very expensive. They're very expensive, and then you have to invest. And then there also has to be a return on investment. If there is no return on investment, then the whole project will fail. So that is where you need to be you have to understand what patients want, the patient's needs, whether there'll be a demand, and what kind of pricing you can apply to this treatment. And those are the few challenges because we are not very well versed with that.
With that business acumen,
Yes.
because doctors are trained for that treating patients. They are focusing on that patient satisfaction. Okay, so sir, when it comes to finances, as you were saying, like it is a very expensive for the upcoming doctors. So sir, what advice you will give to the young ophthalmologists who are selecting this field, that how they will manage their finances and which will help them turn their hospitals run efficiently?
So first of all, you have to learn the trade before learning the tricks of the trade. This is what I tell my students, because if you are very good at your trade, at your craft, and then you are able to give those outcomes which the patients expect, then automatically the patients come in, the volumes come in. And it is a win-win situation. You will have to assess the needs of the patient. And I always say, see what you can afford to give your patients, not what the patients can afford to pay you. If you can afford to get that equipment and give that service, and then it's very good, then automatically the patients also will be willing to pay for the services.
Pay for the services, exactly. And sir, plus what are the skills they need when you're doing a surgery? It is a very tough job because someone's life is in your hands. So sir, there must be a skill which separates best great doctors from the
Yes, because you cannot get actually involved too much in emotions. You have to be very clinical when you are dealing with a patient. Okay, but you should have the empathy. You should have the empathy and the compassion. I have operated on a lot of VIP patients. Most of the governors of Karnataka I have operated. I have operated on film stars. I've operated on my own parents and grandparents and my relatives, my sister, my children also. I have done smile for my daughter.
Okay.
So when I actually see the eye, it's just the eye. It is not the person behind or my relationship or all that. So all that doesn't come into my head. It's just that when I see the eye, it's like Mahabharata. You know the story
Yes.
when Drona asks Arjuna as to what you see. Then he says, I see only the eye of the parrot. So you have to be very focused. If your mind is not focused, then you will not be able to deliver and do a good job. So focus is very important in this profession, especially as a surgeon, and to have the right mental attitude. So sometimes, surgery is a very fluid situation. Things can kind of go wrong. Machines may not work, or patients may not respond exactly as you want them to. So it's a very fluid situation. So you should be able to adapt. And this is what I call the algorithm of the surgery. So step by step, okay, if this step happens, then I go on to the next step. If there is a problem, then I will take an alternate route. So this is what I tell my students. So if you have a complication during surgery, it's just a change in your surgical plan. Don't get mentally flustered about it. And if you have your surgical algorithm cut out for you, then you will know exactly what to do. So when you know what to do, you're not nervous or you don't get the jitters. So you can proceed. It's just like you have a roadblock. Google will give you another direction and you finally reach your destination. So you have to keep your calm. For a surgeon, you have to be very calm. So they say a surgeon should have the eyes of a hawk, a heart of a lion, and the fingers of a lady. So these are some of the qualities. This is what our professors used to tell us when we were students. But I think it is very true.
So sir, like one question, like you are a biker, then you like to sing. Then you are an avid traveler. You are a fitness freak. You are a great surgeon. Every person is having that limited time, just 24 hours a day. You are doing surgeries, you are having travel plans, you are giving international presentations. How do you manage time?
Time management is everything in life. Most people have stress because they are not able to manage time. They are not able to kind of plan their activities, and if they are not able to finish a particular activity, then it gives rise to stress because there are deadlines, timelines, and you're not able to finish that work, and then you're under tremendous stress. So time management is everything. So if you are able to kind of manage your time, then you can have time for your profession, you can have time for your health, you can have time for your family and your hobbies. So this is the work-life balance. So you will have to learn about this during your early stage in the profession, because with medicine, it's a very hectic schedule and there's a lot of stress. In fact, there's a saying that most of the drug addiction, suicides, divorces happen among doctors. Because it's a very stressful job. You're working sometimes like 14, 16 hours a day. And then especially some of the other specialties like anesthesiology or neurosurgery or gynecology, obstetrics, you're working almost round the clock. And then specialities like ophthalmology, we don't have so many emergencies. So it's much easier to plan our time. And you have to be efficient. You will have to look at the workflow. It's called workflow efficiency.
Hmm.
So you train your staff. You also embrace technology to help you, so that you can get a lot of work done in a short period of time. So it's not about working hard, it's about working smart.
Smart.
And this is something that I have learned. And for example, my cataract surgeries, I do about 15 cataract surgeries in an hour.
Okay.
And there are surgeons who take 1 hour to just do one surgery.
One surgery.
So if you're able to efficiently manage your time, then you and use your staff and your support efficiently, then you can get a lot done. So I work 9 to 5. I don't work very long hours because I need time for my fitness. I need time for making my presentations, making my talks for conferences, and also I need time for my family. And I'm able to manage it in the given time. We only have, everybody has 24 hours.
Sir, what insight you have given me is like, it's not about the time, and it's also about the mind management. Like when you are doing the surgery, you are fully into it. When you are with family, you are fully with the family.
It is about compartmentalization. So you need to kind of compartmentalize and be in the moment. That's very important. As a surgeon, it is very important that you don't think about anything else when you're doing your surgery. You have to be 100% focused on the eye, on the patient. In fact, we play music in our OT, so the patient also is calm and the flow goes on very easily. There are no distractions. Phones are not allowed in the operation theater. It's completely focused on the patient. And when you're with your family, you have to focus and be there along with the family, have conversations with them, have dinner with them. You shouldn't be on your laptop doing your emails. So you have to plan time for every activity. So when you have, of course, you need to also set aside time for your health. If you go to the gym, then you're focused there. You put off your phone. You don't answer your phone. You just do that activity. You can always, the other things come in later. You can always message people. So it's not that, and many people are always on their phones looking at social media or messages or chatting. That's a problem we see today. And that is very distracting because then you're not able to be in the moment. If you're not in the moment, then you don't enjoy your life. The secret is to be in the moment. Whatever you're doing, you have to be focused. Because that moment is everything that you have. Once it is gone, it's no longer there.
So we are not using like technology as a tool. We are using it as a destructive forces of our for our mind also. Like we are wasting our time and we are damaging our brain. Like it's a saying, like what you put in, that comes out. You put the garbage in, the garbage comes out. Sir, even you have a nickname of a Faco Maverick. Is that because you do surgery within 2.5 minutes?
I do things differently. I have my own techniques. And so, yes, I kind of got the nickname Faco Maverick. Even my email is like Faco Maverick. That's why it's like that. And yes, I'm a little different from the other surgeons. I have a lot of innovations also. Because when I look at something, I have alternative thinking, whether this can be done in a different way, can it be done better? And I have invented a lot of instruments. I have patents even for a new intraocular lens. So some of these devices are not perfect. But the thinking is that we always think in boundaries. So when I say A for, automatically you think apple. Because the human mind is tuned and trained for what we are taught from childhood. We don't think about anything else. A can be there for so many things, but as soon as you say it, it's for apple because you have been trained. The mind has been trained. So our thinking is like, it's like putting blinders to a horse. So we only kind of think in our boundary. We don't go out of that boundary.
We are creating a box.
Yes, you're creating a box and you're confining yourself to the box. So once you think out of the box, literally, then you have a lot of innovations and you can get, new ideas and do things differently. And that's what sets you apart. And that's how I actually, in primary school, I was not a very good student because the teacher wanted verbatim you know the same thing that they told. You need to by heart and then tell them. I was never able to do that. I'm never able to read from a script. I want to just speak my mind.
Yes.
And I want to form my own sentences. So that's always been my funda from when I was a child. And
So
probably
you
that
were
has
like
helped.
thinking out of the box since childhood, and that's the, like, you can say that's a secret. That's a secret. You have got the key. So are you following spirituality?
Yes, I am more of a spiritual person than a religious person.
Okay.
So I believe in a higher force. I also like to connect to the cosmos. I take my time for meditation, which is very important. And I feel everybody, if they just meditate 15 minutes a day, it's very difficult to reach 15 minutes because your thoughts are, your head is full of thoughts and it's so distracting. So if you're able to kind of set aside even 15 minutes for meditation, then your mind calms down. And it's so much easier. You're so much more relaxed.
So the calmer the mind, the better the surgeon will be.
Yes. For a surgeon, you have to be very calm. You have to be calm. You have to be patient.
So, sir, what's your morning routine looks like?
Morning, I usually wake up early. I go to bed early. I sleep by 9:30 or so.
Okay.
I get up by around 5:30. Then I finish my morning ablutions, and then after that, I do some of my emails. And go through some of my messages because whole day I'm working. I'm not constantly on my phone. So then I do that and maybe a little bit of reading, and then I go for a walk.
Okay.
I walk for about an hour. And before I used to go for a run. But now I just kind of go for a walk. It's quite relaxing. We have the botanical garden near our house, Lalbagh.
Okay.
So I just go there for a walk, come back. Talk to my wife, have breakfast, and then I start surgeries by 9 o'clock.
9 o'clock. Okay.
And then I finish my cataract surgeries, and then have a short break, relax for some time, and then do some half an hour administrative or financial work because we have about 600 staff, 9 hospitals now. So staff come to me at that time, and then after that I go and finish my refractive surgeries, LASIK. So on an average, I do about 25, 30 surgeries a day. Before it was more. I've done as many as nearly 90 surgeries a day.
Okay.
But, and on an average, I used to do about 40 surgeries a day. Now I've actually cut down my work because, of course, my other colleagues and juniors also have to do more work. So I do mainly the premium surgeries and, of course, the complex cases. And then after my refractive surgery, then I have outpatient for about an hour and a half. I see about 15, 20 patients. And then I'm kind of done. Then usually we have a gym in the hospital. So I go there and then work out for about 45 minutes.
So you're a fond of a yoga also?
Yes.
Okay.
So sometimes I kind of do yoga in the evenings after I go home.
Okay.
And then after the gym, I have any other meetings or administrative issues. And normally by about 5:30, I pack up and go home.
Okay.
Then I just relax and then have time for some reading or other activities. Spend time with the family. I have an early dinner. I eat by about 7 o'clock.
Okay.
And
so that's also the key. Like I've read somewhere that, like, if you want to stay fit now, you should have your dinner like before 7:30 p.m. So like you should have 2 hours to digest that food. Is that
generally? Yes, because when you sleep on a full stomach, there is regurgitation.
Okay.
So the food actually comes back into the food pipe.
Okay.
And you can have acid reflux and all those problems. So it's ideal to kind of eat about 3 hours before you sleep. So if you're sleeping before 10 o'clock, then by 7 o'clock you finish your meal. And then you can do your other activities. And then sleep by 9:30, 10. So you're comfortable, you get a good night's sleep. So that's what I follow.
So now let's move on to that major concern in India, which is myopia. what do you think? What's the major reason like we Indians are having this kind of a problem?
It's not only India,
Hmm.
it is a global issue. It's
Okay.
known as the myopia epidemic.
Okay.
Now, most of the health problems
Hmm.
are lifestyle problems. So,
Okay.
this is what people have to realize.
Hmm.
And instead of turning to medicines,
Hmm.
okay, they need to actually look inward at their lifestyle
Hmm.
as to what they're eating, what are their habits, what are their practices.
Hmm.
And these are the things that are giving rise to illness.
Hmm. Hmm.
Anything you take, diabetes, hypertension, cardiac problems,
Hmm.
they are all lifestyle. Myopia is multifactorial.
Hmm.
Of course, you can have myopia because of hereditary problems. If the parents are myopic, then there is a chance, like a 50% chance, that the child can be myopic.
Okay.
That's one of the reasons. But then you see, even if the parents are okay, the child is myopic nowadays. That's again because of excessive screen time. Human eyes are not made to see computers or screens for a very long time. You start accommodating, and then there is a natural response because you're seeing something very close for a long period of time. You develop short sight. With children during the growth phase, if they are constantly on phone, on computers, then this can affect their eyesight, cause myopia. So that is environmental and lifestyle issues also, apart from the genetic probability of undergoing of having myopia. So this actually has become an epidemic. After computers have come in, after mobile phones have come in, you can see most children become addicted to screens. Either they're playing video games, or they're on social media, or using computers for learning, iPads for learning. And during the COVID period, they were all online classes. So we actually saw a jump in the myopia and even progression of myopia. People wearing glasses, the power increased. I mean, the children wearing glasses, the power increased. So this is definitely a lifestyle issue. And before, we used to see it mainly in the Asia Pacific region, Singapore, Japan. These are countries where they have high myopia, even China. India also, and even in the Western nations where they had long sight, more of long sight, now they are having more of short sight now. So this is called the global myopia epidemic. And this is because of lifestyle, also nutrition. So nutrition also, if the child does not have proper nutrition, the child cries, they want junk food, they get addicted because of all the contents there. And then parents also, to keep them quiet, they keep feeding them junk food, and then this leads to a lot of problems: obesity, malnutrition, and even you need the essential vitamins from fruits and vegetables. Very important for proper development of vision. So if that is lacking, then also it is a problem. And children nowadays you hardly see children playing in the street or on the or in the playground. Most of them, after they come back from school, they're again on their computers. So this also causes a problem. You need sunlight, at least 20 to 30 minutes of sunlight every day for because it's not only the vitamin D production, but also for what is known as the circadian rhythm, because blue light in the ultraviolet light is very important for normal sleep wake cycle. And sleep is very important for normal development of all the organs, including your brain. So this is very important. Children don't get enough sleep, again, because their sleep cycle is disturbed. They are watching TV, or they are on the screen late night. So all these are lifestyle issues. So all these problems finally boil down to lifestyle. And then if there is a change in the lifestyle, then automatically we will see all these problems coming down. But now, because of this epidemic, we see more and more children wearing glasses. When I was studying in school, there were only like a couple of kids wearing glasses, and we used to always tease them and make fun of them. Now more than 50% of the class are wearing glasses. And we are seeing this increasing, and by 2050 it is said that almost 50% of the human population will be myopic. So that is actually worrying. And sometimes myopia can progress. If it's high myopia, more than 6 diopters, then you have other problems. You can have retinal issues like retinal detachment
Okay.
and other issues. So it's very important to kind of be aware of this. At Netradama, we have actually launched a myopia clinic. It's a special clinic where we can screen children. We have special instrument called the Myopia Master. It checks not only the power, but the curvature of the eyeball, the length of the eyeball, all the parameters. And it also gives you a chart of myopia progression.
Okay.
So there are some treatments to reduce the progression of myopia. So you have special glasses. These are glasses with lenslets, which cause peripheral defocus. So this actually has found to reduce the progression of myopia. You also have drops like low dose atropine drops. This also prevents the progression of myopia. So then we do the assessment, and then actually the chart gives us the progression without treatment and with treatment. When the child is around 18 years, what will be the final power? And so regularly we need to keep checking every 6 months once, and then we put them on treatment and also counsel them about the lifestyle and use of screens, about nutrition, about getting sunlight, all these things. And this is an initiative that we have started.
And, so that's a very good initiative.
Yes. And we will be conducting school eye screening programs. We go to the schools.
Okay.
Conduct school eyes, and children who are in need of further assessment, they are referred to the myopia clinic. So we do a full assessment, put them on treatment, so that at least we can prevent them from going in for a high myopia.
Okay. So, sir, as far as LASIK is concerned, how LASIK works in the treatment of myopia?
See, LASIK basically is laser in situ keratomelusis,
Okay.
where we use an excimer laser. First, a flap is made in the cornea. The cornea is the front surface of the eye. So a flap is created either with a blade, with an instrument known as a microkeratome, or with a laser, a femtosecond laser. So we call that bladeless LASIK because we use a femtosecond laser to make a flap. Then the flap is lifted. Then we use an excimer laser, a second laser called an excimer laser, which actually flattens the cornea.
Okay.
So once it flattens the cornea, then the rays of light actually, which are converging, diverge to focus on the retina. And so we are able to correct the myopia. So there is flattening of the cornea and focusing of light so that the correction is achieved.
Okay. So, sir, as far as advancements are there, so, sir, what's the latest advancement against LASIK?
So the latest advancement is known as KLX or keratolenticular extraction.
Okay.
The company names are Smile, Silk, Clear. So there are different companies which give different names. Smile was the first procedure which started almost 15 years ago. I've been doing it from 12 years. So this is a bladeless LASIK. And it is a flapless LASIK. So we use only the femtosecond laser. The femtosecond laser carves a lenticule, a thin piece of tissue inside the eye, and there is a very small 2 millimeter access incision through which this lenticule is removed.
So it is, sir, not creating that flap?
There's no flap. It is flapless. So the problem is when you have a flap, you are cutting the corneal nerves, so you can have dryness. That is one thing. Second is there is some amount of discomfort because you have to make a 20 millimeter cut, lift the flap, put back the flap. There's also a risk of flap dislocation if the patient touches the eye or rubs the eye, and also flap wrinkling, which can happen if you have not set the flap correctly. These are all some of the issues. There are also other issues like epithelial ingrowth, etc. But most of these flap related problems are totally avoided once you have a flapless surgery. Plus, for patients who want to play contact sports, say football, boxing, then you don't want a flap because the flap can dislocate if you have even minor trauma. So this is very useful, and the recovery also is much faster. With LASIK, it takes a week. Restrictions are there for a week. Here, it's like 24 to 48 hours. After 24, 48 hours, you can play sports, you can go to the gym, you can shower, you can wash your face.
So it's like after 2 days, the person can...
Yes. It is minimally invasive surgery. It's called minimally invasive surgery. So it's through a micro incision, through a 2 millimeter incision itself, and it's totally painless. So the patient doesn't even feel it, and it's a very short procedure. Takes only about 2 minutes per eye. The laser itself takes about 10-15 seconds.
Okay. So, sir, in this, we are also saving that time to make that flap.
Yes.
Is that?
Yes, because there you need 2 lasers. You need a femtosecond laser and an excimer laser. Here it's an all femtosecond laser. So it's only one laser. So the time taken is also much faster. You can finish the surgery quickly.
Okay. So, sir, there is an ICL, that implantable.
Yes. There is also, there are different techniques to correct myopia.
Okay.
Or hypermetropia, which is long sight. These are the refractive disorders. And you have astigmatism, which is cylindrical power. So the first procedure which came out was PRK, or photorefractive keratectomy.
Okay.
Which basically uses an excimer laser to actually reshape the cornea on the surface. This was started in the 1980s. But this again, because there's a raw wound which has to heal, it takes about 3-4 days to heal. We have to put a bandage contact lens. Risk of infection is more. And it is a painful procedure for about 3-4 days until what we call the epithelium, the surface skin, heals. There's pricking, watering, pain. And the visual recovery also is delayed. It takes about 3-4 weeks. And you have to use drops for a prolonged period of time.
Okay, in PRK?
In PRK.
Okay.
So after PRK, there was LASIK, where you make a flap and give the laser. And then came the KLX or SMILE procedure, which is a totally flapless procedure, so that the recovery is much faster. It's painless, less medication, and you can get back to your activities. You can even do contact sports and all. So these are the advantages. Now, there are some patients who are not suitable for LASIK. What is the range? The range for keratorefractive procedures, either PRK, LASIK, or SMILE, is anywhere from 0.5 to -10.
Okay.
So beyond -10, double digits, again, very high myopia, laser is not advised, because you have to remove a lot of tissue when you flatten the cornea, and this can create problems. It can cause abrasions, poor quality of vision, and in the long term, it can weaken the cornea and cause what is known as ectasia, which is very troublesome and difficult to manage. So generally, we don't like to treat more than -10. And we need to kind of check all the parameters. We do what is known as a tomography, corneal tomography, which checks the curvature, the thickness of the cornea, the front surface, back surface of the cornea, creates a 3D map. So we can study that and see if the patient is suitable or not. And only if the patient is suitable, then we take them up for the procedure. If they're not suitable, then the alternative is phakic IOLs, or what we call ICL, implantable contact lens, or implantable collamer lens. So there are a couple of companies making these lenses.
Okay.
These are very thin lenses, which we inject through a very small incision, like a 2.8 millimeter incision. We inject the lens into the eye. It goes and sits under the iris, under the pupil, in front of the natural lens. So it is invisible, you can't see it. And it focuses for all distances along with the natural lens. So you don't need glasses. The advantage of this procedure is dryness is less. It's a reversible procedure. You can actually also remove or exchange the lens. So these are the advantages of the ICL or phakic IOLs. So we do, and for powers which are very high, like more than -8, -10, or the patient's cornea is not very thick, then we can do these lenses. Even otherwise, we can use it depending upon the patient's condition and the requirement. So we have what is known as comprehensive refractive solutions. So we have PRK, we have LASIK. PRK, we have certain indications. Sometimes the surface skin is very weak, what we call basement membrane dystrophy. So for such patients, LASIK may not be safe. So for them specifically, we need to do a surface ablation or a PRK. PRK is known by a lot of names: trans PRK, advanced surface ablation, epi-LASIK. So there are a lot of names, but basically it is surface ablation. Where we use the laser directly on the corneal surface. So in our hospital, we have comprehensive refractive solutions. We have PRK, we have LASIK, femto-LASIK, then we have SMILE, Clear, which are the more advanced procedures, and we have phakic IOLs also. So and for presbyopic patients, like patients over 40
Over
who wear
40.
reading glasses,
Yes.
for them we have a treatment called Press Beyond,
Okay.
which is an advanced type of LASIK. It's a customized advanced type of LASIK where we can correct both distance and near.
Okay.
So I myself got it done about 9 years ago.
Okay.
So I don't wear glasses. And it's we have to assess the patient, and it's a very successful treatment because the general notion is that after 40 years you cannot really do LASIK and you cannot correct the reading glasses. But with this technology you can correct the both the distance and reading glasses. And
so sir, in this procedure we are also taking that corneal layer out of the eye.
we remove some amount of corneal tissue and reshape the cornea.
Okay.
So it is similar to LASIK. It's an advanced form of LASIK for
the presbyopia
patients over 40 who require reading glasses. So this is something that so we have all the techniques. So we do an assessment of the patient. We look at their lifestyle, we look at their eye, we look at their scans, and then decide which is the best, safest procedure for them, which will give them a good correction and what all they need for their particular lifestyle, and then we discuss and then go ahead with that. So it's not that we have only one procedure that is only LASIK for everybody or only SMILE for everybody. So depending upon the patient, we tailor the approach solution, and some of them only phakic IOLs or ICLs may be required. So it depends completely on the patient and assessment of the patient. So it's best to leave that decision to the doctor who is experienced. So some patients come in and say, oh, my friend had LASIK, I want LASIK. But they may not be a suitable candidate for LASIK, but there's an alternative procedure which will give them as good a result. But finally they want to get rid of their glasses and they want to live life without glasses. So we can offer them a solution.
So if a person is like facing a keratoconus, like then how LASIK will work?
Keratoconus is a condition where the cornea starts becoming conical. Normally it is spherical. So it starts becoming thin and starts bulging and becoming conical. Usually it's a progressive condition. That means it keeps on increasing with age and can be caused due to rubbing the eyes. So that's why we tell our patients not to rub the eye. Because it can lead to keratoconus. So for keratoconus, again, these patients are not suitable for LASIK or SMILE. So for them, we need to first stabilize the problem, the keratoconus. We do what is known as C3R or corneal collagen cross-linking, where we put riboflavin drops, which is a vitamin, and then give ultraviolet A radiation. So what happens is cross-linkage happens between the collagen fibers in the cornea and it becomes stiffer. So it stops the progression of keratoconus. In moderate keratoconus, sometimes we may have to use what are known as intrastromal corneal rings. We put in very fine rings in the cornea. This actually stretches the cornea and flattens the cone and improves the vision. These are all for early stage of keratoconus. And later on, for the residual power, we can do a phakic IOL or an ICL. So that is something that we can do. In very advanced keratoconus, they have scarring of the cornea. In advanced keratoconus, these treatments will not work. We will have to do a corneal grafting, and we have lamellar grafting, which you call as DALK, deep anterior lamellar keratoplasty. So the front layers of the cornea are removed and reinforced with the corneal graft.
So sir, as per as like ICLs are concerned, what's the best patient suitable for the ICL? Who is having like minus 10 diopter? This is the one criteria.
See, for ICL, again, for any refractive procedure, the power has to be stable. So usually we do it in patients above 18 years. Preferably 20-21 years, and their power should not have changed much in 1 year. So the change should be less than 0.5 for them to be suitable. For phakic IOLs, we need to actually look at what is known as the anterior chamber depth. So they need a good anterior chamber depth which can accommodate the phakic IOL or the ICL. So we do a scan and we need to take measurements for the lens. So there are few instruments which we use to take the measurements. One is a UBM or ultra high frequency probe, the ultrasound probe which we use, and then take the measurements, and then we do some scans and then check if they are suitable, and then we can do it. You can do it for most conditions, we can treat up till minus 23
Okay.
with phakic IOL. So
Phakic
the
IOLs.
range is quite high,
Hmm.
from like minus 2 to minus 3 to minus 23 we can treat. So
Okay.
the maximum power I have treated is minus 32, where we
Okay.
use a combination of two procedures known as bioptics, where we put in an ICL and then later on correct the balance power on the cornea either with LASIK or SMILE. So this is known as bioptics. So we can treat very high powers also.
Okay. So, sir, is there any criteria like the range of that anterior chamber depth? How should?
Yes, the anterior chamber depth has to be a minimum of 2.8
Okay.
for putting an ICL, but experienced surgeons can put it even in a lower anterior chamber depth, even 2.6, 2.65. I have treated
Okay.
because I've done almost about 15,000 ICLs.
ICLs. Okay.
Phakic IOLs. So if you're very experienced, then you can. But otherwise, generally the range is if it's above 2.8, then there's adequate space
to fit that
the
lens.
lens.
Otherwise, it will lead to.
Otherwise, there can be an increased vault and what we call narrowing of the angle and secondary glaucoma.
Okay.
So these are things that we have to check. The procedure itself is quite simple. We just put drops through a micro incision. We just inject the lens. So it takes like a couple of minutes. To do the procedure.
Okay. So, sir, there is one more issue, that is cataract, which is natural aging of that crystalline lens in the eye. How cataract can be treated, and what is cataracts for the? If you can tell them in brief.
Yeah. What is cataract? Actually, it's interesting. Cataract is a Greek word. It means waterfall. So the ancient Greeks thought that there was a bad humor or liquid in the brain which used to descend in front of the eyes and cause blurring of vision. And that's why they called it cataract.
Okay.
So that's the kind of history. But cataract is nothing but opacification of the natural lens. So everybody has a natural lens in their eye. It's about 19 to 20 diopters, the power of the natural lens. And that keeps changing its focus.
Okay.
So when you contract your muscles inside the eye, the ciliary muscles, then the power of the lens increases and you're able to see nearby objects. In a relaxed state, you see the distant objects. So this is how the mechanism of accommodation works. So this lens, as you age, becomes harder. So after 40 years, it kind of reduces its ability to focus, and that's why you need reading glasses. And as you get older, above 60 years, then again, it's multifactorial cataract, genetics, environmental exposure to UV light, and nutrition. All these factors can cause opacification of the lens. Natural protein lens, it gets opacified, the protein gets denatured, and then causes blurring of vision, and that is what is cataract.
Cataract. Okay. So, sir, what are the treatment options for it?
Cataract, now the latest treatments, you have different types of surgeries. So what is followed now, you have small incision cataract surgery, which is a manual surgery. It's a sutureless surgery. In the earlier days, we used to do what is known as extracapsular cataract surgery, where we used to make a very big incision, 14 millimeter incision, remove the cataract as a whole, put in the intraocular lens, and then suture the wound. With the SICS, small incision cataract surgery, you need to make a 6 to 7 millimeter incision. You make a tunnel, which is self-sealing, so that it doesn't need sutures. Then you extract the cataract as a whole and remove it. That is a particular type of surgery which is done. Mainly we do it in CAMs and where we have high volume and mature cataracts where it's easier to do this. Then the gold standard is what is known as phacoemulsification. Phacoemulsification is a technique where we use an ultrasound probe, and through a small micro incision, 2.2 millimeters to 2.8 millimeters, we actually emulsify the cataract. The cataract is broken up into pieces and sucked out of the eye. And the capsular bag is left intact, through which we put a foldable lens. So through the small 2.2 mm incision, we inject a flexible foldable lens, which is made of acrylic or silicone. And this goes and then opens inside the eye. It's actually 6 millimeters in diameter, the optic, and it has got supporting haptics.
Okay.
They go and sit in the bag. and replace the natural lens. This is an artificial lens so that it focuses. Now, even these lenses, you have different types. We'll talk about that. The other procedure, the latest technology is laser cataract surgery. It's called FLACS, Femto Laser Assisted Cataract Surgery. FLACS.
Okay.
So many people gave it different names. They simply call it laser cataract surgery, or they call it robotic or semi-robotic surgery. But it's actually not a robotic surgery in the real sense.
Okay.
There's no robo doing the
surgery.
So it is only the laser which makes all the important steps of the surgery. The incisions in the cornea, it's a customized treatment. So it measures the cornea and the cataract, makes incisions in the cornea. If the patient has astigmatism, you can make relaxing incisions to treat the astigmatism up till 1.5 diopters.
Okay.
And then the opening in the cataract, what is known as the capsulorhexis, this needs to be very precise. And with the laser, you get the maximum precision. You get the exact size and shape, circular capsulorhexis, and then it cuts up the cataract into pieces. So it's easy to suck out the cataract from the eye. So it's very precise. And we actually did a study between phacoemulsification and laser cataract surgery. And we found that laser cataract surgery, the accuracy improves by about 8 to 10%.
Okay. In laser-assisted
cataract surgery. So now I mainly do laser-assisted cataract surgery, especially for premium intraocular lenses.
Okay.
Intraocular lenses, there are different types of intraocular lenses. The standard is what we call a monofocal intraocular lens, which focuses only for distance. So the patient will have to wear glasses if he wants to see intermediate and near. And people end up wearing glasses all the time, progressive glasses, because in today's world, you need intermediate vision for your phone or to see or to read, all that. So they end up with progressive glasses, wearing it most of the time. Then you have another category of lens, which is a multifocal lens or trifocal lenses. These focus for distance, intermediate, and near. All three distances. So essentially, patients don't have to wear glasses. In this also, there are different types of lenses. The diffractive lenses have rings in the lens.
Okay.
So these rings, diffractive rings, can cause some disturbance at night. The night vision is not very good. So when you look at light, you can have glare and halos, big circles around light, which can be uncomfortable. Especially people who drive at night, we don't recommend these lenses, highway driving and all that. There is a new lens called the Femtis, which is actually made for the femtocataract procedure.
Okay.
And this is the latest advance. It fixes onto the capsulorhexis margin, which is made by the laser.
Okay.
And the outcomes are very precise. And it focuses for distance and near, and also to some extent the intermediate. And the night vision and quality of vision also is better than the trifocal lenses.
So it doesn't have that rings.
It doesn't have rings. So it's like a varifocal kind of a lens, which has focuses for different distances. And we find that patient satisfaction is very good with this, minimal complaints. Then you have the other category, which is known as the EDOF or extended depth of field lenses. These lenses are monofocal lenses, but with an extended depth of focus, and they focus for distance and intermediate. So because in today's world, intermediate vision is very important, whether you want to see a phone or you want to see your iPad or laptop. So the night vision and the quality of vision is good with these lenses. So people who are driving at night, who are living an active lifestyle, who don't want to wear glasses most of the time, then the extended depth of field lenses, the EDOF lenses, are quite good. Because they can be independent from glasses for most of activities, but to read small print, they will have to wear glasses. So they need readers to read. If you want to be totally free of glasses, then you have to go in either for a trifocal or the Femtis M+ lens. If you want a reduced dependence on glasses, then you can go for this extended depth of field lenses. So these are now the lenses, intraocular lenses, which are available. And depending upon the patient's lifestyle and what they want, what is the kind of vision they require after the surgery, then we have a questionnaire, we talk to them and then take a decision on what type of lens.
So like even the lens is implanted according to the lifestyle of the patient.
Yes.
Okay. So, sir, like how this EDOF lenses work?
EDOF lenses basically they stretch the focus.
Okay.
So any lens, it focuses light to a point, to a point focus. So the EDOF lenses, what they do is there is a little bit of change in the curvature of the lens.
Okay.
They actually, this is called spherical aberration.
Okay.
So they have some amount of spherical aberration, which actually stretches the focus.
Okay.
So because of this, they get some amount of intermediate vision. That's how it works.
That in the center they have that spherical aberration.
Yes, they have a spherical aberration which focuses light not to a point, but actually it stretches the focus, so it's like a line.
Gives that range of vision.
Range of vision. Yes.
Okay.
That's called.
So, sir, is there any complications using these lenses?
Complications as such, whatever lens you use, the procedure is the same. The implantation technique is the same. You have to be very accurate in what we call the biometry or the measurements. We take measurements of the lens. So we have very advanced equipment, what are called optical biometers, to measure all the surfaces of the eye, the length of the eyeball, and then there are formula which calculate what is the power to be used for that particular lens.
Yes.
And for a multifocal lens to be successful, you have to be within 0.25 power.
Okay.
For spherical power, and cylindrical power within 0.5.
Okay.
So we have toric lenses also. Toric lenses are lenses which correct cylinder. So if a patient has cylindrical power, then when he sees an object, the object appears stretched. The quality of vision is not good. So with a toric lens, when you put in a toric lens, this astigmatism or cylindrical power is corrected, so that the rays of light come to a sharp focus, and the quality of vision is good. So in a multifocal lens, you can have a multifocal toric or a trifocal toric. So then these are for patients who have astigmatism also along with cataract. And this corrects the astigmatism and improves the quality of vision. So the astigmatism has to be within 0.5 for a trifocal or multifocal lens to work well.
Okay.
So the measurement has to be very precise and accurate.
Okay. So, sir, as far as you were telling that these multifocal lenses or trifocal lenses, they have that rings which causes halos or glares, but they give spectacle independence to the patient.
Yes.
So, sir, what are the suitable patients for that?
See, basically patients who are not driving at night, who are not very demanding, but they want full range of vision. They want distance, intermediate, near. They are not bothered about the night vision. They are not doing any highway driving. So these are patients who are, and they want independence from glasses. They don't want to wear glasses. These are patients in whom we recommend these lenses, so that they are free of glasses and they can do all the normal activities. People who drive actively at night, especially highway driving, we avoid these lenses because the night vision and quality of vision is not that good.
Okay.
You may have seen what are known as Fresnel lenses. They were there before. We used to put them on our TV screens to magnify. They had this rings, diffractive rings. So that's the similar kind of technology. So the quality of vision is not that sharp, but you have independence of glasses. So you have a full range. You can see distance, intermediate, and near. So there is always a compromise. We have a saying, there are no free lunches in optics. So it's physics. So we don't have a lens which can mimic the natural human lens. So there is some amount that God has created. We are looking for solutions for an accommodative lens, but so far there's no lens that can change its shape as the patient kind of looks at distance and near.
Okay.
So that's why we use these roundabout technologies to give them distance, intermediate, and near. So there is a little bit of compromise when you go in for such technologies in quality of vision, night vision. But most patients, I would say 95% of patients are very happy. It's very, very important to assess the patient, have correct measurements, and to do a meticulous surgery. And then you get good results. In fact, my parents, both of them, I put in trifocal lenses.
Okay.
They're older, they don't drive. They're mostly inside the house, and they don't want to keep searching for their glasses. And they're very happy and they're doing well.
Okay. Sir, as far as eye care is concerned, what do you think where Indian industry, Indian ophthalmic industry or Indian eye care industry is at global stage?
I think the Indian companies are doing very well now.
Mm-hmm.
And some of them are even exporting intraocular lenses to places like Europe, and they're being used there. So some of the companies, the quality is very high. I am also on the advisory panel of few of these companies. Before, we used to just depend on imported lenses because we didn't have the access to technology to manufacture them here. But now, of course, we are very proud because in India, Make in India is working. There are some companies which are making excellent products which are being exported all around the world and being used, both intraocular lenses and phakic IOLs. And this is something, the trend which is actually picking up. But there are certain advanced equipment like the excimer lasers and femtosecond lasers, which we still are not able to make in India, or the advanced microsurgery equipment like microscopes. So we have in our hospital we have a 3D microscope, where basically you are wearing the 3D glasses, looking at the screen and operating. And we had the first global installation from Zeiss for the 3D microscope. And I'm a consultant to Zeiss, and I help them develop products also. So we have to depend on technology from abroad if we want to get the latest cutting edge technology. But many of the technologies are also available in India. They are, of course, available at a lower price. And what we are seeing is the quality is actually improving. And now the quality is almost on par with the global, some of them with the global companies.
So, sir, what's your take on that? Like collaborating with that Indian manufacturers and taking that on global stage?
Yes. In fact, I have a few innovations and patents, and I'm working with some of the Indian companies. I have worldwide patents on a new type of an intraocular lens, a capsulotomy fixated lens, which actually it removes some of the side effects of the normal intraocular lens. You have what is known as negative dysphotopsia, and sometimes the lenses rotate, the toric lenses. So this new design takes care of all those things. So we have actually now we'll be doing the clinical trial shortly. Once we get the permission from the drug controller. And hopefully we should be able to project it on a global platform.
So, this lens you're working on, is it the intraocular lens or it
It's
will
an
be
intraocular lens.
it's an intraocular lens.
It's
It's
an
not that it's an addition to intraocular lens.
No, it's an intraocular lens. For a phakic lens also, we have some new designs. So there are a lot of interesting projects, and like I said, I have a few patents for all these innovations. And hopefully in a few years we will be able to bring it out.
So, sir, let's conclude this podcast with the last question. Like, what do you think where our ophthalmic industry will be in 10 to 15 years? Will India will be at that stage where we are seeing like these American companies are doing great? Will India will be there?
See, if you look at eye care in India, see, India has the highest number of blind people in the world. And most of this blindness is reversible, and it is because of cataract. We have almost 9 million cataract patients who require surgery. So there is a lot of demand, but again, the supply is less. Most of these patients are also in the rural areas, and they don't know that a surgery can cure them. So there's illiteracy, lack of knowledge. Also, there is difficult to access eye care. And what is happening today, what we see is that there is a lot of investment coming in eye care. So there are a lot of investors who are investing in eye care, and there are a lot of chains which have propped up. And but these are commercial chains because the investors want profit. So basically, they are for profit. So most of them are in the urban cities, which are there in the urban areas, in the cities. And almost every street has an eye hospital or eye clinic. And they're competing for the same space. Because, again, it's for profits. But most of the blindness is in rural India, and this is a problem, access to care. So we actually have a trust called Shraddha Eye Care Trust, where we do about 10,000 surgeries, free surgeries every year. We have 2 base hospitals, and we have buses which goes to the rural areas. We do the screening there. And we are also associated with the National Program for Prevention of Blindness, what we call the NPCB program, or the DBCS program, where we are coordinating with the government. They allot areas, rural areas, where we can go do the screening, bring patients, and operate them. And we also have a lot of the NGOs whom we have tied up with, who help us in this work. And we do about 10,000 surgeries every year, the free surgeries.
Okay.
And this is something that we have been doing from 2000. Shraddha started in 2000. And then it is a not-for-profit organization run by a board of trustees. And this is something that, again, the community service which we are doing. We also do school eye screening for refractive disorders and squint and other things. So this, in India, there is a gap. So we need to kind of fill the gap. And of course, equipment is expensive, intraocular lenses are expensive, but now Indian companies also have started manufacturing. So this will actually reduce the gap. The government also has taken certain initiatives, like the GST for intraocular lenses was high, and then they have kind of reduced it to 5% now, which is good. And if they can also kind of waive off customs on some of the equipment which are essential for surgery, because eye problems are huge in India, that will be very effective and helpful. So this is where we stand. But with time, what happens is the load of this preventable blindness will come down. And of course, the Indian companies and the ophthalmic industry, we do actually in India, we do the maximum number of cataract surgeries in the world. So our surgeons are very experienced. If you look at the developed countries, if you look at their operating list, they operate like 2 or 3 days a week. They do about 4 or 5 surgeries. Here our surgeons do like 20, 25 surgeries a day.
So they are more practiced than they?
Yes, we are highly skilled, and we are very efficient in the workflow. And this is something which actually, it is the need, so we adapt to that. But over a period of time, I think this preventable blindness would come down. But what we see is that I think more people have to actually do some amount of rural service and community service to reduce the blindness. So that, because the trend is now for investments and investment coming into eye care, a lot of investment coming into eye care, and then only these commercial chains which are being set up. So that is a trend which is not very healthy. If you look at the overall picture of blindness in the country, preventable blindness, where we need to kind of bridge the gap, and then also offer services to the rural population and the underprivileged. So that's what we are looking at. So yes, my life has been a bit of everything: community service, research. We have more than 100 publications.
Yes, sir. I've read like few of them, like the lenticule extraction.
Yes.
It's on lenticule extraction, but it was a way more technical for me.
Yes. We have a lot of publications on refractive surgery, cataract surgery, and we have training programs. We have a lot of education, research and education going on. So it is a kind of a wholesome approach. And so I enjoy doing everything.
So it's about making an impact.
Yes, it is about giving back also. And I always believe that you should give back more than you take. And that is fulfilling in life. If you are able to give back more than you take, and give something to the society and make yourself useful. And also mentor and teach your younger colleagues
Hmm.
so that they become successful. I think it is very important.
It's about taking that younger generation forward.
Yes, you have to take everybody together. I think everybody has to pitch in, everybody has to be successful also. And yes, that has been my life's goal. So that
So it's a saying also, na, that alone you go fast, but together you go far.
yes. In fact, the cornerstones of our practice, we call it trick. The core values: teamwork, respect, integrity, and compassion. So these are the cornerstones on which our practice has been built.
So thank you so much. It was a very insightful conversation with you.
Thank you.
It really made my day.